Insulin was discovered in 1921. The scientists who developed it sold the patent to the University of Toronto for $1 each, because they believed a life-saving medicine should be available to everyone who needed it. One of them reportedly said the patent should not be held by any individual. Today, a single vial of insulin in the United States can cost over $300. The same vial, made by the same manufacturer, sells for under $30 in Canada. This is not a manufacturing problem. It is not a research problem. It is a pricing system, and understanding how it works requires understanding an industry that has spent decades building structures specifically designed to keep prices high, competition low, and the public confused about why. The United States pays 2 to 3 times what patients in Canada, Germany, or the United Kingdom pay for identical medications from the same companies. The standard industry explanation is that high American prices fund the research and development that produces new drugs. There is partial truth in that claim. Drug development is genuinely expensive, but the full picture is considerably more complicated. The first mechanism is the patent system. When a company develops a new drug, it receives exclusive rights to sell that drug for roughly 20 years with no generic competition. This makes some economic sense as an incentive for innovation, but the industry developed a strategy called evergreening, making minor modifications to an existing drug and filing new patents on those changes. Each new patent extends exclusivity. A drug that should have gone generic instead stays protected for decades, generating profits long after the original research investment has been recovered. The second mechanism is called pay for delay. A brand name manufacturer pays a generic competitor not to enter the market, even after the original patent has expired. The generic company accepts because the payment is more profitable than competing on price. The brand name company accepts because it is cheaper than losing its monopoly. The patient pays full price for years longer than they should have. The Federal Trade Commission has estimated pay for delay costs American consumers billions of dollars every year. The third layer involves companies most people have never heard of: pharmacy benefit managers, or PBMs. PBMs sit between drug manufacturers and insurance plans, negotiating which drugs get covered and at what price. Manufacturers pay PBMs rebates in exchange for favorable placement on covered drug lists. Those rebates are based on the drug's list price, which creates a perverse incentive. Higher list prices generate larger rebates for the PBM, while patients paying at the pharmacy pay more. The result is a system where list prices bear little relationship to what anyone actually pays, and no single party has a clear incentive to lower the price a patient ultimately faces. In 2022, the Inflation Reduction Act gave Medicare the ability to negotiate drug prices directly for the first time, a change the pharmaceutical industry had blocked for decades. Some prices came down, but the structural incentives have not fundamentally changed. Evergreening continues. PBMs continue operating without transparency. The United States continues paying more than every other wealthy country. The insulin that cost $1 in 1921 is still being made. The chemistry has not changed. The patients who need it have not changed. What changed is the system built around it, optimized over decades to extract maximum value from the people who have no choice but to pay. Follow and subscribe for more, and drop a comment. Have you or someone you know ever had to ration medication because of the price?